is on evaluating the baseline, measure up, pressure down. It's presented by Dr. Ashok Rai, the CEO and President of Prevea Health in Green Bay, Wisconsin. We're also here today with Karen Handmaker, who will be moderating the session. She's the Vice President of Population Health Strategies at Vital. Before we begin, I want to go over a few housekeeping items. First, you have a control panel on the right side of your screen. You can minimize and expand the panel by clicking on the red arrow in the upper left-hand corner. Second, you can submit questions using the area located near the bottom of the control panel. We will take time to answer any questions you may have during the Q&A period of the presentation. If your question was not answered, we'll respond to you individually after the event. Finally, all registrants will receive a copy of the presentation and a link to the recording after the webinar. At this time, I'll turn it over to the session moderator, Karen Handmaker. Karen, you may begin the webcast.
Thank you, Renee. We are very pleased to have Dr. Ashok Rai with us today to present Prevea's roadmap for improving rates of hypertension control using population health workflows and integrated technology. Our learning objectives for today are to walk you through how Prevea developed its hypertension quality initiative to align with the AMGF National Measure Up, Pressure Down program, and to show the measurable results that Prevea achieved in just 2 months using a combination of Vital tools, embedded care managers, and new workflows. Dr. Rai will also articulate lessons that Prevea has learned from this initiative that can be applicable to your organizations. And as Renee indicated, we have allotted time at the end for your questions. So now let me introduce Dr. Ashok Rai. As President and CEO of Prevea Health, the largest multi-specialty group in Northeast Wisconsin, Dr. Rai has a personal commitment to the wellness of this community and works to inspire others to live well. His association with Prevea Health began in 2001 when he joined Prevea's partner hospital, St. Mary's Hospital Medical Center, as the medical director for hospitalist services. During the past 10 years, Dr. Rai has served as St. Mary's Physician Quality Director and Prevea's Associate Medical Director of Operations, Senior VP, and Chief Medical Officer. Dr. Rai's passion to redesign healthcare has led Prevea to focus on the PCMH model of care and to create a medically based wellness program designed just for business, featuring customized programs that educate and empower employees for a healthy and fit lifestyle. Dr. Rai?
Thank you very much, Karen, and good morning, everyone. I have a slide deck that we'll walk through regarding our story on helping to control blood pressure and increase our rate of measurement as well. And as Karen stated, we'll be reviewing some of our workflows and how we integrated embedded care managers and technology into those workflows. Just to begin, obviously, looking at the impact of hypertension throughout our country, we all know its serious effects, also known as a silent killer, what it does to blood vessels, our heart, and kidneys, and leading to more secondary illnesses as well. In 2010, it was estimated, when we look at the cost of hypertension, not only in medical services, but also in drug costs, to be around $93.5 billion. And we do know that healthy lifestyle behaviors can reduce blood pressure significantly, such as stop smoking, increasing physical activity, reduction in excess weight, salt intake, and stress management. But for us as physicians to be able to address that, we need to be able to see those patients and engage them away effectively in our office. Specifically, when looking at diabetic patients who also have hypertension, if we're able to control blood pressure in that population, we can decrease our risk of heart disease by as much as 50%, and the risk of microvascular calcifications, such as complications such as peripheral vascular disease, by 33%. When looking at blood pressure within an organization, I think it's always good to understand what the scope of the issue is within your own patient population. By using some of the tools that Karen mentioned earlier through Vital, we're able to look at all of our active patients over the age of 18, and we looked at them in 2 different ways. One, through our billing data, so looking for 2 hypertensive codes through ICD codes and E&M combinations. So in other words, whether we billed it, or in our EMR section, if we actually had it on our active problem list within the last 2 years. We were able to narrow our patient population down to about 21,973 patients. And then we eliminated those who were pregnant or had end-stage renal disease because they obviously require a different type of monitoring protocol and in some cases, obviously, their blood pressure is short-term or limited due to pregnancy. So it really got us down to 21,680 patients with hypertension who we felt, and looking at the measure up pressure down criteria, should have their blood pressure monitored at least annually. So when we looked at how well we were doing, we weren't all that disappointed. 94% of our patients had a documented blood pressure measurement within the last 12 months, but we weren't effective in reaching out to about 1,300 or so patients. We did find a lot of variability, and I think it's important not only to understand that not only did we look at a broader population, we also looked at it between practice groups. And what we mean by that is our different sites. In a lot of our sites, we have family practice and in internal medicine. They practice in separate departments, but at the same location. And we have multiple sites, like many of you do, in the multi-specialty group environment. So 7 of our practice groups are doing very well. Their percentage of measuring of blood pressure in the last year was over 95%. 8 of our practice groups were between 91 and 94%. And the remaining of them, and I'll show you a chart, were characterized by lower volumes. And you would probably understand with lower volumes, we have a higher degree of variability, and their hypertension scores were anywhere from 30% to 89%, but sometimes only missing 1 or 2 patients in a very small site could have created that. And here's kind of a listing, just so you can get a representation of the size of the practice, and then how many patients had a percent without a blood pressure taken, and then the number of patients that actually accounted for. So you can see a small site, it only takes a few patients to throw off increasing the variability. At the very large sites, we were doing very well at 95% or better. Not only were we focused on making sure that we could measure blood pressure, but what were we doing with that blood pressure when we actually recorded it? And our rate of achieving the target blood pressure, it was already better than the national average of 53.5%, but looking at AMG's measure up pressure down objectives through their foundation, the goal is to get 80% of their patients managed at a therapeutic target. And that was defined as a systolic blood pressure less than 130 with a diastolic less than 80. Those are the patients with diabetes or chronic kidney disease, and all of our other patients with a systolic less than 140 and a diastolic less than 90. And of the high blood pressure patients, hypertension patients that actually had their blood pressure measured in the last year, 30% had a measurement indicating they were above the therapeutic target. So that was concerning that we had 6,000 patients out there that in one way or the other we weren't addressing it at a rate or a control rate that was where we wanted to be. So how we got here to where we're at, about 6 years ago, we implemented automated messaging to identify and notify patients due for recommended care. And we did that through the Vital product and outreaching to our patients telephonically for those that had not had an appointment in the last 6 months and not one scheduled for the next 4 months, really making sure that we were reducing the patients with noncompliance. And to us, we were defining noncompliance as essentially not being seen. And at the same time, we also replaced episodic care with coordinated care, long-term care through an adoption of the patient-centered medical home, and received NCQA recognition for all of our primary care locations. And just to give you a sense of scope of Prevea, we're definitely not the largest in the country. We're the largest in our area, and we have 18 on-site care managers right now working through that. So not only were we automating our process to identify patients and bringing them in, but once they were in, we were using care management to get better control and to make sure that, once again, the patients weren't being lost to follow-up. So we're happy that we were better than the national average, but as a medical group, we've never really considered average to be our goal. And like most people, we want to be in that top decile, and that's really what we're aiming for. So our hypertensive patients who are receiving those automated communication messages were significantly more likely to have both a chronic care-related visit and a blood pressure recorded in our EMR, and we actually published this, and you can see our statistical odds ratio there in our confidence interval. We were very happy with those results. And 76% of our hypertensive patients cared for under the medical home model improved or were at the therapeutic target after 12 months, versus 52% who are cared for under our traditional delivery care system, which is obviously just a single primary care physician trying to do everything, not in a team-oriented way, and really in an episodic, see the patient and hope they'll come back and see you again rather than continuous engagement, which is really what our medical home model is. So despite some of these good results, our blood pressure control and compliance outcome measures have remained static over 18 months. So we made a really big increase, and then we plateaued. And that plateau still did not get us to where we wanted to be in that top decile. So we were looking at the Measure Up, Pressure Down initiatives coming through and challenged ourselves to a 60-day challenge to pick some pilot sites and see if we could make a difference. And then if it worked, obviously spread it throughout the rest of our organization. So we looked at 4 pilot sites, approximately 8,000 hypertensive patients. We re-examined our delivery system and really revised our current protocols. We noted we had extreme variation between care managers themselves. So every care manager was working with a group of physicians, and although they were each doing a good job for their site, there was a lot of variability, and they weren't able to really articulate a workflow response. They knew what they were doing, but it wasn't standardized, and that was frustrating to us, and I think in a lot of ways frustrating to them. Some departments were rechecking blood pressures at the visits, others had different protocols. We really didn't have a standard for follow-up care. Some had follow-up at 2 weeks, some at 4. Others really didn't have a standard. It doesn't mean that they weren't following up the patient, but it could be anywhere from 1 to 6 weeks. And we really didn't have a standard for documenting the second reading, even if it was done at all. And some of that was a build issue with our EMR, which we were able to address through this pilot. We also felt that if we were going to standardize how we were going to measure and treat, we also needed to standardize how we were going to educate our patients, because so much of hypertension control isn't as much about pharmacotherapy, which that's still a component, but we still need to educate our patients, and we can make a significant impact through education. So we updated our educational material both on healthy lifestyle, smoking cessation. Not only did we find education to increase physical activity, but we found areas for them to do that, what we call a prescription for fitness, at a local health club that we partner with, really focused on the reduction of dietary salt, and offered some public classes and also things within Prevea to address stress management. We also worked on addressing barriers to access within our system. So if a patient was found to be hypertensive, but we didn't have an appointment available for them, we were failing that patient. So we were looking at how we were going to address those barriers and to make sure that this cohort of patients was a priority. And really looking at the patient's non-adherence to treatment, and it was that a lack of education, was that funding for pharmacotherapy, were there other options, did they not have a ride? We were looking at all of those different options. And once again, finding solutions to insufficient access to healthy foods and physical activity, and how could we conquer that in the community as well. So we didn't look at this as just a small pilot. We really wanted to redesign how, as an organization, we were addressing blood pressure. So part of what we talked about is we didn't have standards. So in the 6-day pilot, we got our providers at those sites to agree to a standard way of dealing with this very important issue. So during the rooming of a patient, if a patient's blood pressure was over 140 over 90, or once again over 130 over 80 for patients with chronic conditions, right away it was added to the chief complaint. So the provider had a flag. Most providers will look at the vitals when they walk in the room, but obviously the chief complaint is what's focusing them, and whoever was doing the intake at that time put it within the chief complaint to really bring it front and center for that provider. And then we expected the physician to actually repeat the blood pressure at some point during that visit. We do know the concept of white coat hypertension, the ability to rest that patient for some time, to question them about their caffeine use, and then to repeat the blood pressure. And then we arrange follow-up with the care manager. So once again, we're approaching this problem as a team and not just having the physician repeat that visit. Follow up with the care manager visit for 2 weeks if we weren't making any changes to medications, or if we weren't starting any medications, or 4 weeks if we're making changes to medications, to really make sure we gave it enough time to, number one, to see if the patient was tolerating the medication, because it does take some time for that to happen for those who've prescribed or used hypertensive meds, we know there's an accommodation period, for lack of a better word. So 4 weeks made more sense. And the care manager was going to take blood pressure and a pulse at the follow-up visit and route that encounter to the physician. So once again, it's a team approach to blood pressure control and workflow development, making sure that the physician was always in the loop, even though they weren't the ones seeing the patient. The physician then had the opportunity to give directives back to the care manager around medication adjustments or follow-up need. So just to diagram what those workflow improvements were, this is our elevated blood pressure workflow. Once again, if we didn't see, if we saw blood pressure that needed to be targeted, we put it in the chief complaint, brought it front and center, repeated the blood pressure, and if it remained elevated, one of two things needed to happen. Were meds started or changed today? If they're elevated, if it wasn't, if the blood pressure came down, obviously we didn't have to do anything. But really where the pathway continues is if we were to either change the pharmacotherapy or add it. And once again, if meds were started or changed on that day, and we'll go to the bottom here, we have a 4-week period to allow for accommodation. And we added essential hypertension patient education to the ABS, or our after visit summary. Sorry about the abbreviations here. And if we didn't, we had them follow up in 2 weeks, basically at the assumption there that maybe we didn't need to start medications yet. Maybe there were other factors that we can control without having to either add pharmacotherapy or change it. But we didn't want to go too long without seeing that patient, so that's hence the 2-week follow-up. And once again, education was the cornerstone on the after-visit summary. So our other aspect of our follow-up visit workflow is really more on the internal care management standpoint, where the care managers then, as they were able to identify their cohort of patients using FITEL and registry development, where the care managers essentially were able to place calls to the patients and make sure they could schedule those care manager visits. They had their own workflow where the rooming nurse was checking the blood pressure. In the progress of that care management, we created what we call a dot phrase to document recent blood pressure readings as well. We routed the nurse visit encounter to the provider, so once again making sure the physician was in the loop, and the provider giving feedback, and then a care manager following up based on the status of that patient. Once again, if pharmacotherapy was changed or added, 4 weeks, if not 2 weeks if it was still elevated. Once we had our workflows, and I mentioned some IT tools that were implemented during those workflows, I kind of want to take a few slides here to maybe expand a little bit more what those tools are. Number one is identifying where we had variability and learning from best practices, and for that we needed transparency. And I'm not sure how well this slide is projecting for you all here, but this is where we're able to look at current performance of different groups. So every colored bar you see there is a different practice site, and we're looking at our goal for hypertension control. And we can monitor the degree of progress. We also can monitor the degree of compliance through their performance. We're able to look at best performers, and we're also look at weak performers and take a deeper dive. So once again, having a snapshot by site is what the tool allowed us to do, rather than just an aggregate piece of data. So the ability to drill down was key for us. And then at the site area, the ability for the care managers to look at registries either created for them or created by them using the product. In the registries were to look at gaps in care really created based on appointment dates, providers, the assignment to the care manager to a specific subpopulation such as hypertension, and really looking at where they're going to coordinate care and what was done from a self-management standpoint. So the ability for every care manager to basically pull up a screenshot, know where their patients are at and what they have to do next was key to us as part of that workflow. And then when we got to the individual patient level, essentially, for a lack of better words, and those of us who are old enough like me to remember paper charts, the concept of chart prep. Now, obviously, when we're using electronic medical records, it's more flipping through tabs, still very inconvenient. But to have all of the chart prep data aggregated to one screenshot like we have here through the product that we're talking about today, the case manager or care manager is really able to drill down what they need to do for that specific patient and also look at trends for that patient without having to, to do too much time in flipping of tabs or calculating a trend. Everything you see here is automated. So what happened with our pilot clinics? Was this worth it or not? So you're looking at our baseline in green and 60 days after, and looking at what we were doing with blood pressure measurement. And as you can see, the lowest scoring pilot clinic was still measuring at just under 96%. So we did see improvements at every single site with the pilot, which is obviously what we were looking for prior to rolling this out system-wide. And then looking at blood pressure control, once again, our control rates are in the orange 60 days after with the baseline in green. And you can see we were reaching higher control rates at the different pilot sites as well. So we knew whatever we were doing there in a very brief pilot, I need to stress 60 days is usually not enough for us to see really significant results. But we were happy just within 60 days the type of results we were seeing. And look at what they're doing today. Once again, if you remember that first graph, you can see our percentage of patients without blood pressure has gone down basically throughout. We still have variability in the very small sites, but we're getting better even in those very small sites. And then the total number of patients without blood pressure is also reflected as well. So overall, fast forwarding to where we are today, and the nice part about the tools we're using in our partnership with Vital is we always know where we're at, so we know if what we're doing here needs to change, or if all of a sudden the protocols that we have out there people stop following, people have busy days, and sometimes routines change. So we want to make sure we're monitoring that. But today, 98% of our patients have a documented blood pressure measurement within the last 12 months, which is great. And our hypertension managed to the therapeutic target within our primary care sites is at 71%. So 8% away from the AMGA goal, and once again, getting closer to our own internal goal of being in the top decile. So what did we learn? We learned a lot during the pilots that we've put on and how to use the tools. One of the things is we learned we must account for growth and access in primary care. So as we're onboarding new providers, making sure that they're aware of well-defined protocols. You can have all of the IT tools you want in the world and EMRs, but unless they're used in some sort of standard workflow, and that the providers understand what that workflow is. And by providers, remember it's a care providing team, so maybe a new RN care manager or maybe a new family practitioner. As we grow, if we're not educating that we've got well-tested, pilot-proven, data-proven workflows that we'd like them to buy into, and at times you can start practices and forget that aspect, then we start to see our numbers getting worse. So that was what I wanted to talk about when we really look at access for growth, is to make sure that your workflows, once they're established, literally become part of orientation. And also, when you're reaching out to patients, making sure that, especially with a disease like hypertension, that you have the access to get them in and the workflows associated with that. So they may not need to see a physician every time, but sometimes just a care manager visit and electronic communication with the physician will lead to great care and great numbers, as you've seen with our numbers. You need to update that patient education within our EMR regularly. We did learn we were pretty out of date, even with what we educated a patient on what target was. And given the new technology around self-monitoring at home, what were we doing to help with that? So really working on our education. And whenever we open up a new clinic, making sure that the workflow standpoint that is talked about is rolled out there too. We're not dictatorial as an organization. We're collaborative. But there's certain things that when you know work well, that the workflows are working well, that they're pilot proven, that you have the data to prove it, you do have to at some point take a stance and say this is not optional. And in this case, we had all of the data. We had pilots that were working. They were continuously tweaked with a multitude of different specialties having input. What I mean by specialties here, not just physicians, but nurses, rooming nurses, care managers, even those who schedule appointments. Everybody had input. Once you've gotten that, you can't make it optional, and that was very important to us. So our next steps, where do you go from here? We still have a little bit of work to do, but like I said, it's 1 year in now, and we're continuously seeing an improvement. So what we were doing is working. But what do you do for non-treating departments such as ophthalmology or orthopedics or general surgery? What are the responsibilities for those departments when they establish or see a patient with hypertension? What is the workflow there? And we do have an onboarding process and a workflow responsibility where they are routing that information to the site's care manager so the patient doesn't get missed. Because so many times they may not be interacting directly with primary care, but being a multi-specialty group with over 60 sites, they may be at another site, maybe it's even urgent care for a cold, and we realized we picked up essential hypertension during that visit. What are we going to do about it? We need to have those standard protocols. We have those now, and that's something that we've definitely learned from. Addressing physician resistance to allow care managers to own major parts, as you notice that there is that. Right now, a year after the pilot, this has really gone down significantly, and we've shown them data, and bringing other physicians who are working with care managers forward to talk about it was very important to us. So the pilot site's educating their partners, and this is essentially dissipating now any kind of resistance. Develop similar models for sites without care management. Not every site is big enough to have an on-site care manager, so we're looking at centralized care management for those sites, even some of our embedded employer sites, and how we could work better since we know that this workflow works well and it has results. Testing and retesting every single pilot, whether it's 60 days or 6 years, you need to be able to know where you're at and continually test it. As we saw with the Phytal product, we can break it down by site. We can quickly see if the site is starting to become non-compliant because of a variety of issues. Some of them may be new providers or people not oriented to the process, but continuously making sure you're looking at it, not being happy with your data, and then 2 years later being surprised and saying what happened. And what did we expect to happen versus what did we observe, and really looking in that to see if there needs to be any workflow changes. The workflow we have today is working well, but new IT will come out, new pharmacotherapy will come out, and we continuously need to make sure that we're getting the types of results that we were expecting. So that's really what I had for our Measure Up, Pressure Down story. I wanted to leave enough time for interaction with all of you. I know we've got people from a variety of different sites and a variety of different practice styles. I'm happy to speak even more about how we use the product within our workflows or how we even came up with those workflows, but wanted to make sure we describe them to you first and then open it up to questions. And I think, Karen, you're going to moderate those for me.
Dr. Ayers,
Right then.
Okay, great. I'm actually going to open up the queue here in just a moment. The first question that we have is, which Phytal tools are used for Measure Up, Pressure Down initiative within your organization?
So we look at insights, see where our data is at, and outreach, obviously, to look at, to automatically look at our blood pressure patients, high blood pressure patients, and bring them back in, and use Remind for appointment reminders and coordinate as well to help with those patients within the care management tool base.
I also to add for everybody that Phytal has created within the Insight tool a report that can easily be downloaded to submit the quarterly results to AMGF if any of you are interested in participating, any of you Phytal clients that are out there who are interested in participating in this initiative.
Okay, next question. How many PCP medical homes received NCQA recognition and at what levels?
They're all at level 3, the highest level of recognition, and I think we are at 18, but don't quote me, that number may have gone up.
Next question. Last guideline to address blood pressure measurement recommends averaging blood pressure regarding readings during a visit. How have you approached this?
So we're talking about the latest guidelines when looking at should you average multiple readings. I think that's the question I heard, and how we approach that. Mm-hmm. The latest guidelines and looking at that and redoing our workflows to accomplish that. Obviously, doing the average reads is not as easy because the EMRs aren't really designed to do that for us. So it is creating a level of frustration. So it's a little bit of a mental manual process right now. We haven't changed our workflows to allow for the averaging yet.
Okay, great. Next question, what data registry tool is used?
The data registry tool that we're using is within Phitel. And then our EMR is Epic. So Phitel is drawing the data from our Epic product and creating the registry for us.
Okay, great. One of the other questions that just came through, could we get a co-management example agreement? Karen, is this something that we can provide?
Co-management example agreement. I'm not sure if I understand that question well enough, because we don't have any written agreements between our providers and the nurse practitioners and the care managers. There isn't anything that's actually an agreement put in place. Is that what the question was referring to?
That is a great question. I'm not sure it wasn't expanded upon. So if that person does want to expand upon the question, please go ahead and submit it through the question portion, and we'll try and answer it more thoroughly for you.
Or feel free to email me directly. Yeah.
Great. We'll share your email address too at the end of the presentation. So at this time, I'll move on to the next question. How are the care managers being utilized other than visits?
Other than visits, they are actively reaching out. So it's not only a visit to us in a situation with care management is not only the in-person one-on-one reaction. They are on the phone a lot doing coaching and educating. They do educational visits, for example, and they also assist the physician with new diagnoses and education. So if it's a new diabetic or a new hypertensive, the care manager may actually pop in the office right after the physician, and that's part of our workflow. So the care manager is doing a lot more than just in-person visits.
Okay, great. Next question. Are the care managers RNs or NPs or a combination?
RNs.
Great. The next question, where did you get standard for blood pressure goals?
The blood pressure goal standards came from the AMGA's foundation, which is known as the AMGF. I use the right initials today. Their Measure Up, Pressure Down campaign. So we looked at that as a national, really high benchmark, and then where did we want to be, and that's how we set our goals. And for those of you who would like more information on the Measure Up, Pressure Down initiatives through the AMGA, you can go to the AMGF website by going to I think there's a link off the AMGA website, and Karen, you could probably provide that to the attendees as well.
Yep, we'll definitely follow up with that as part of the information that gets sent to attendees after the webinar. Thanks.
Great. Next question. Did you use outreach to automate patient care prompts?
Did we use outreach to automate
patient care prompts?
What was that last one?
Prompts.
I think we should talk about, Dr. Rai, how you've generally implemented outreach many years ago, as you referred to in the program. That was your first hit, if you will, for the program.
Right. What we did with outreach, or how we used it, is we really focused on diabetes and high blood pressure initially. And we're looking at, when we first turned on the product, we had a very large cohort of non-compliant patients. And we basically determined non-compliant patients, like I mentioned, as people who we weren't seeing that we knew had blood pressure. And at that time, we were only looking at our billing data. We had not done the interface with the EMR data. We were actually the first organization to do the Epic Vitel interface, so have the longest history on that. And that's how we used outreach going back then and how we use it going today. We've added many more protocols now to prompt patients to basically interact with us. And then when the patients do call us back, our patient service representatives, or what we call PSRs, have a screen that they're able to navigate to see why we reached out to that patient, and then have workflows identified for them if they have high blood pressure based on the pilot workflows that we have.
Okay, great. I just want to remind everybody, we have been receiving quite a few questions. We are recording this event, and we will send out the link as well as a copy of the presentation. You should receive it within 24 hours via email. Another question that has come in, Karen, this is for you. Has Vitel considered the Million Hearts Initiative in any of this work?
Yes, definitely, and we have several clients that are participating in that, and these initiatives align quite nicely. And if you have any more questions specific to that initiative, you can email me directly, and you'll have my email in the materials that come out after the webinar.
Next question, are the calls made by Vitel to the contact the patients documented in your EHR?
The calls going out are not posted back into our EHR. We have that separate screen that I mentioned through Vitel that our PSRs are looking at when a patient calls back.
Great. I'm just checking to make sure we are answering all the questions we can, since we still have some more time. All right, who are the typical care managers? RNs or MAs or something else?
They're registered nurses.
Okay, I think that was another question that we answered earlier. Second part to that question, also, how do you staff for extra visits by the care managers?
How do we staff for extra visits by the care managers? So the care managers actually have their own scheduling system within Epic, and they usually do their own rooming, so there's no extra staff needed for them. They occasionally, if an MA is available, will rely on the MA to help them through some of their workflows. But the care managers set their schedule so they have enough time for impromptu visits, like I mentioned, the scheduled visits, and then time for their telephonic education and reaching out to patients, because we wanted to make sure the care manager had multiple mediums to touch our patients, making sure that those who needed more intensive therapy were in person, those who needed just quick follow-ups could be done on the phone. Wanted to make sure they had a schedule that allowed for all of that.
Great. Next question. How does this process apply to a newly diagnosed hypertensive?
So the newly diagnosed hypertensive, if I were to, it's the same process, and I don't know if they can still see my screen, but I'll actually try to take us back to the workflow slides. And pardon me for that. So this workflow is actually for new or already diagnosed hypertensive patients. This is what happens when we find out somebody just has an elevated blood pressure. And once again, it's added to the chief complaint, so that could be a newly diagnosed patient, or they could be there for their diabetes and have high blood pressure. We know it. It's just more elevated today than it should be. We repeat that blood pressure. It remains elevated. And at that point, there is a judgment call for any provider, depending on, in talking to the patient, understanding their other comorbidities, and their genetic history, their family history. Is pharmacotherapy recommended on visit here, or do we see them again in 2 weeks to make sure that the blood pressure we're recording today isn't one that was transient, or is not one that we could maybe affect through simple lifestyle modifications and see them back again? Obviously, if it's a new patient and we start pharmacotherapy, or if it's an existing patient and we either add or change pharmacotherapy, it's a 4-week follow-up for us.
Okay, next question. Has there been any patient attrition due to the more time involved with improved blood pressure measurement?
Patient attrition as in have we lost patients because of this? Not that I could identify. Actually, we're busier than we've ever been.
Next question. How many case managers do you have for your patient population?
We have a total of 15 that would focus on primary care, 2 within cardiology, 1 within gastroenterology that's really focusing on heartburn, and that person is a nurse practitioner because of some of the work that she's doing, and actually it's 19 now because we've added 1 that is working part-time focusing on pediatric obesity.
Okay, great.
Our patient population, we saw about 700,000 visits last year, probably, total identifiable patients around 200,000.
Okay, great. Next question. How are the automated calls or prompts initiated?
We have a multitude of protocols with Vital, and Karen, you're probably better qualified at explaining the protocols than I am. I've literally lost count on how many we have going on right now, and it's an automated initiation. So once we start that protocol, it's on cruise control for us, and then we get the data back from Vital of how we're doing on engaging those patients. So whether it's high blood pressure, whether it's diabetes or COPD or asthma or pediatric immunizations, there's a different protocol for each. The data is mined basically on a daily basis at a certain time period, and calls go out based on those protocols.
Dr. Rye, you did an excellent job describing the outreach program. If anybody has any additional questions, please follow up with us, and we will get you specific information for you.
Okay, great. We have another question. Does this tool allow the care managers the ability to create their own system spreadsheet for following these patients that are included in this initiative?
I can answer that one. Absolutely. Yep, sure, you're welcome. In the tool, the care managers can assign specific patients to themselves, or they can be assigned patients to follow by others like the physician or a quality director or others designated with those rights in the program. And this enables a care manager, for example, to open her list every day, see changes in the list, because if people, based on certain criteria, meet the criteria for being on the list in the first place, then they will drop off. So the list is constantly updated every day with new information for those patients, unless the care manager just wants to track them as a static cohort.
Okay, great. Next question. What seems to be the biggest barriers that remain for hypertension control with your patient population at those sites where the pilots have now been completed?
Probably the biggest barriers are ones that aren't going to shock you. It's access to medications for those that don't have it, and then it's lifestyle modification. It is Green Bay, Wisconsin, so the images you see on game day in the parking lot are real. That is our patient population. They could be healthier. They could be a lot healthier. We're working on that, but we're not going to change the culture here overnight. So a lot of what we see in resistance is lifestyle modification, whether it's smoking cessation, obesity, just simple activity measures. It's a huge focus for our organization to change the culture here, but it isn't going to happen overnight, and that's really what we see as our biggest issue. With pharmacotherapy the way it is today, we can address some of the genetic issues. We know the right, based on racial and ethnic backgrounds, we know it's going to work well. Any comorbidities we're able to manage as well. But the things that you can't control, and if you were to ask our care managers what's their dream, it's to show up at the patient's house and look in their cupboard and look in their pantry. That was the #1 request I had when I had a chance to do home visits, not home visits, but one-on-one visits with our care managers, asking what they wanted more in their, to help take care of the patients. One was their own education, and they got that actually through a national conference this week. And secondly, the ability to just raid the pantries of their patients.
Okay, great. Next question. Have any of your sites considered, or do they currently use, automatic blood pressure cuffs as a solution to the average of the 3 manual readings?
Yeah. So it's a quality committee debate right now, but yes, we are looking at that. And then what's the standard for that? Who's responsible from a biomed standpoint to make sure that those machines are audited and accurate? Because we're going to make some pretty big decisions based on those those automated machines, whether it comes to pharmacotherapy, and so we want to make sure that things are working right.
Okay, next question. What is the ratio of patient to care manager? How many patients in care manager's caseload are there?
You know, I don't have that offhand, Karen. It's a little under, well, it depends on our care manager and what they're doing with their time, but it's around 1,000 for some and 300 for others.
Yeah, but that, just to clarify what I think you mean by that, you might have 1,000 patients on your list, but they're not all high priority or active.
Oh,
they
yeah.
might be based on a condition cohort definition.
Right.
But then, right, so the tool allows you to flag patients that you are actively working on or that are high priority, and to be, managing them. So in our experience, that there are different levels typically of care managers, whether you want to call them case managers or care managers, and for those patients that are the most complex with multiple comorbidities and other issues, they're usually a care manager can work maybe, 50 to 100 of those actively, and then the next level down you can go to several hundred patients if you're, managing generally healthy patients but wanting to help modify and monitor their risk levels. You can take on a larger caseload. And then the automated communication tools that Phytel offers, makes it a lot easier to do that because you can send a email or a phone letter or a letter campaign to every patient with information, for example, about blood pressure, or asking them to check in with you as the care manager, see how they're doing, or remind them about an upcoming program. So that enables the care team to go deeper into the population than they otherwise would with just manual tools.
Okay, great. Next question. Oh, sorry. Go ahead, Dr. Rice.
No, I said thank you, Karen.
You're welcome.
Okay, great. There looks to be just a few more questions here in the queue. Next one is, how long are average patient appointments for initial and follow-up appointments?
Standard, I wish I could pull up somebody's template right now. We call a follow-up or brief office visit, depending on the site and the skill level, anywhere from 15 to 20 minutes, and then anywhere from 30 to 45 minutes on an extended office visit, and then physical times are an hour.
Great. Next question. How do you manage patients with white coat syndrome?
I take off my white coat. No, sorry. Just joking there. We've looked at different strategies, as have multiple providers around the country. Home blood pressure monitoring is an example of that. Definitely looking at different time periods in the day, because white coat hypertension is not always associated just to coming into the practitioner's office, but there's certain things that people do in the morning, such as caffeine consumption and different variables that also need to be looked at, not just being in the provider's office, but a well-calibrated instrument or a skilled provider taking that blood pressure outside of the environment is one solution as well. And because we have a very active patient portal into our EMR, we're able to communicate back and forth and log those blood pressures into the EMR as well.
Okay, great. Another question, this is a two-part question. First one is, can you describe your patient education material development in greater detail? And then the second part to that. Sorry. Go ahead.
Our quality department, through advice from a quality committee, actually develops those materials or gets them from outside sources, makes sure that as much as we can embed into the EMR as we can, we do. so that it's part of the after-visit summary. So we've used different vendors to incorporate that education, making sure it fits not only the national standards but also within our organization the standards of how we want to communicate with the patient, making sure that it's multilingual, which is a big issue for us as well, and that's why using some of the national vendors where we can actually incorporate it into the AVS has been a big priority. But it's really the quality department that does that research, runs it by our quality committee, which is the team of physicians, making sure that it's accurate, fits the latest guidelines, and then is rolled out within the EMR through our IT team. And then training is done, and by having it within the EMR, the training is pretty similar as it is for all of our education. It's just highlighted as being there for high blood pressure.
Okay, great. Actually, that was the end of the questions. So let me just double check one more time. All right. Dr. Rai, can you go to the last slide, please?
Yes, I can.
All right. Karen, while Dr. Rai is moving to that last slide, was there anything else that you wanted to add or any other questions that you received?
No, but I would certainly encourage everybody on this call who Phytel clients and Phytel friends to please contact us for more information and look at our website. There's white papers out there. There's other links to relevant webinars, and certainly you can contact me directly if you would like to learn more.
Wonderful. Thank you. Dr. Rai and Karen, I want to thank you again for your time today. We really do appreciate it. For everybody else on the call, please let us know how we're doing. At the end of this presentation, as you log off, there will be a very short survey for you to take. If you can do that, we greatly appreciate it. Our next executive webinar series is on Succeeding in Medicare Advantage with Risk Management Tools. It will be presented by John Mark Harmon, Product Manager here at Phytel. It is September 25th from 12:30 to 1:30 p.m. Eastern Time. You have Dr. Rai as well as Karen Haymaker's email on this presentation. So again, this will be sent out along with the recording within 24 hours. Please look for it via email. At this time, the webcast has ended. Have a great rest of your day and a fantastic weekend. Thank you, everybody.
Thank you.
Thank you.